Good morning, everyone.
Good morning.
I'm Oluwaseun Falade. I work at the Baltimore City Health Department STD clinics, running the HIV programs we have there, and also serve as faculty at the Johns Hopkins School of Medicine. I am so excited to be here this morning to share with you some of the work we have been able to do in Baltimore with the support of the CDC. I am going to start by talking about hepatitis C in Baltimore. Now, unfortunately, we don't have a lot of good surveillance data, and that's because reporting of hepatitis C is very limited. We do have research data, however, and this research comes from two groups. We have the ALIVE cohort, which is a cohort of injection drug users that have been followed in Baltimore for over 20 years. And in that cohort, over 80% of patients are infected with hepatitis C. Dave Thomas, who works in the School of Medicine, had actually done a study in the Baltimore City STD clinics in the 80s and focusing only on individuals who denied ever using injection drugs. The rate of hepatitis C was 9.7%, so really high rates of infection. And so we went into this project aiming to increase the proportion of persons who were aware of the hepatitis C status, and also to link individuals infected with hepatitis C to HCV care. Given what I've told you about our prior knowledge of hepatitis C in certain subpopulations, and our knowledge of high rates of injection drug use in Baltimore, we felt pretty confident that the community prevalence of hepatitis C would be rather high. We looked to test individuals individuals aged 18 to 70 years of age. They were Baltimore City residents who resided in Baltimore in 2013, and as such were accessing the STD clinics for care. I'll tell you, the population is a predominantly African-American population and is largely medically underserved. 54% of the patients we take care of in the STD clinics live below the poverty line. And so these patients have a lot of competing urgencies. They have to think about housing, food, employment, and this in many ways makes it difficult for them to prioritize healthcare. Our project was funded by the CDC Foundation and the Viral Hepatitis Action Coalition. The Baltimore City Health Department has two STD clinics. Our model of care is for nurse practitioners and physician assistants to provide care. It's a walk-in clinic, so patients come in, they register, they get an appointment, and they get seen. It's a very busy clinic. We provide HIV testing. We provide care for 400 infected HIV patients. We do hepatitis B screening and immunization. We do STD testing and immediate treatment. We also provide pap smears and pregnancy tests. We see over 30,000 patients a year in these two STD clinics. Busy clinic? It's a major source of healthcare for the surrounding medically underserved communities. And so we feel very gratified working with our patients, and which is why we thought that this would be a really great avenue to screen individuals for hepatitis C. How do we diagnose hepatitis C? You start with an initial hepatitis C antibody screening test. The antibody test tells you if an individual has ever been infected with hepatitis C. Because we know that up to 25% of patients can clear infection, every patient who is antibody positive needs to get follow-up HCV RNA testing. If the HCV RNA testing is positive, then that individual has active hepatitis C infection. Traditionally, this was done with a lab-based test. So you took a sample from the patient, they went to the lab, and then the results came back in 5 to 7 days. And this has been a limitation to actually delivering results to patients, because a lot of patients don't come back, and so they never do get that result for hepatitis C testing. In 2011, a rapid test for hepatitis C was approved in the US. This test was approved for use on venous blood, so you could get the blood by doing a finger prick, or you could take blood from a vein and then do direct testing on the collected blood. Results are available in 20 minutes, outstanding test. The clinical trials actually show a sensitivity and a specificity of 100%, suggesting that every patient who has hepatitis C who is tested using this test will be identified. And so for our project, we chose to integrate it seamlessly into the STD clinic activities with the aim to get every patient their results before they left the clinic. As I told you, it's a walk-in clinic, so patients come in, they sit in the waiting room. While they're sitting in the waiting room, we have a very entertaining video. It's called Hepatitis C, The Basics. It's actually a cartoon which narrates the natural history of hepatitis C. It talks about individuals who are at risk of infection and the availability of treatment for hepatitis C. By the time patients get to the registration desk, they already know something about hepatitis C, so that when they're offered the test, they make an informed decision about whether they want to get tested or not. I will tell you that 80% of the patients who are offered the test actually have accepted the rapid hepatitis C test. The patients who choose to get tested are then channeled to one of our rapid testers who will do a finger prick. In addition, this tester also administers an alcohol audit. It's a very simple 3-question interview aimed at identifying patients who have risky levels of alcohol use. The patient then goes to see the clinician. By the time the patient gets to the clinician, the hepatitis C result is ready, so that the clinician, in addition to providing STD care, is also able to do post-test counseling for that hepatitis C antibody result. Part of that discussion is the need for additional testing, so the HCV RNA, which will let the patient know whether they have active infection or not. In addition, there's a brief alcohol intervention. As Bryce so eloquently talked about just a couple of minutes ago, alcohol use is such an important part of progression of hepatitis C, liver-related disease. Patients that are not immunized for hepatitis B also get immunization at that time. The patient then goes to the phlebotomist, who, in addition to drawing blood for the HIV test or the syphilis test, also draws blood for HCV RNA testing for individuals that are antibody positive. The patient then gets a return visit in 1 to 2 weeks. So again, the return visit is a walk-in appointment. The patient can come in anytime during clinical hours, which we find is very convenient for our patients because they don't have this fixed time at which they have to be there, otherwise, without which they wouldn't get seen. At that follow-up visit in 1 to 2 weeks, the patient sees a clinician. The clinician focuses purely on hepatitis C. At that time, there's a discussion of the HCV RNA test result. Further medical education is provided. The patient gets counseling on prevention of transmission of hepatitis C to others. For patients that are also drinking alcohol, they get additional alcohol counseling. And then there's a very brief discussion of hepatitis C treatment options. The patient is then seen by the project coordinator. As I had alluded to, our patients are medically underserved. A lot of them don't have active insurance. And so we saw that that would be a huge barrier to getting treatment for hepatitis C. So there's an insurance evaluation that goes on at that time. For patients that are uninsured, the project coordinator discusses potential insurance applications and also assists with applications for insurance. We assist with scheduling an appointment with a hepatitis C treatment specialist. And with a generous donation from the Johns Hopkins University School of Medicine, we have been able to offer our patients free FibroScan tests. So a FibroScan is the trade name in the US for transient elastography. This was a test that was approved by the FDA in June of this year for non-invasive assessment of liver disease severity. As Bryce had said, one of the big concerns with hepatitis C disease is that it causes damage to the liver. And so one of the things we want to know upfront is how much damage there has been to the liver. The FibroScan is kind of like an ultrasound-like test. It measures the degree of liver stiffness and is able to tell us whether a patient has significant liver damage or not. Because our patients have so much going on, we try to meet them where they are and help them with as much as we can. So in addition to all this, we also help patients find primary care physicians. We link them to substance abuse treatment programs, mental health programs, and job programs. And I'll present for you our preliminary results.